Over the past 3 decades, the coronary artery calcium score has evolved into a central instrument for cardiovascular risk stratification. A score of exactly 0, commonly called the power of 0, is now regarded as the premier negative risk marker in preventative cardiology. For asymptomatic individuals, this score provides significant prognostic reassurance. It suggests a high probability that the patient will remain free of major cardiac events in the short to intermediate term. However, the clinical utility of a 0 score depends entirely on the patient's presentation. While it defines a low-risk category for routine screening, its interpretation changes when a patient arrives at the hospital with active chest pain. Pooled analyses indicate that 15 to 20% of younger patients presenting with acute coronary syndrome, or ACS, a sudden blockage of blood flow to the heart, actually have a calcium score of 0. This presents a physical contradiction. We're seeing patients with a perfect score of 0, while they are in the midst of a life-threatening plaque rupture. Non-contrast CT imaging captures macroscopic mineralization, but it does not account for the total burden of atherosclerosis. The true value of the score is governed by the limits of imaging physics and the rules of Bayesian probability. Standard calcium scoring uses the Agatston Method, which relies on non-contrast, ECG-gated CT scans. The score is calculated by measuring the area of a calcified lesion and multiplying it by its density. This method operates on a strict physical cutoff. The scanner only registers tissue with a peak attenuation of 130 Hounsfield units or higher. As the digital plane sweeps across the artery, the dangerous, lipid-rich necrotic core of a plaque falls below this threshold and simply disappears from the scan. Dense macro-calcification indicates a plaque has stabilized and is less likely to rupture. But a standard scan's blind spot hides the most dangerous components. With CCTA, we can see the non-calcified soft plaque that remains invisible to the Agatston score. Beyond these visible blind spots, there is a microscopic level of physical stress that a standard CT scan cannot detect. Micro-calcifications exist far below the resolution of a CT scanner. These tiny mineral deposits create focal points of mechanical stress within the thin fibrous cap that holds a plaque together. This localized stress makes the plaque significantly more likely to tear or rupture, even if the total calcium score is 0. Findings from the ICONIC trial confirmed this. Symptomatic patients with a 0 score who went on to have a heart attack had much higher volumes of fibrous and necrotic core plaque than healthy individuals. A non-contrast CT is physically unable to detect these microscopic triggers. It provides a measure of past calcification, but it cannot see the mechanical instability of an active, vulnerable plaque. When we move away from the emergency room and look at asymptomatic adults, the data shifts. In the multi-ethnic study of atherosclerosis, or MESA, roughly half of the participants had a calcium score of 0. For these individuals, a 0 score is a biologically distinct low-risk phenotype. It is a unique physiological state, not simply the bottom of a risk continuum. The MESA data showed that people with a 0 score had a 10-year risk of a cardiovascular event between 1 and 1.7%. This rate is remarkably low compared to traditional risk models. The risk is binary. Even minimal calcium triples the risk compared to 0. This affects how we prescribe medication using the number needed to treat, or NNT. For those with a 0 score, the 5-year NNT often exceeds 100. For scores over 100, the NNT drops to between 12 and 25. Because the benefit of statins is so much higher when calcium is present, the 2018 ACC and AHA guidelines suggest that statin therapy can be deferred in most asymptomatic 0 score patients. In low to intermediate risk patients, this score provides a 15-year warranty period, where the annual risk of mortality remains below 1%. This warranty is not permanent. In heavy smokers and diabetics, the disease can progress much faster, shortening the period of safety. When the initial probability of disease is low, the 0 score is a robust, evidence-based reason to avoid unnecessary lifelong medication. Everything changes for patients with stable or acute chest pain. In these cases, the reassurance of a 0 score is significantly diminished. This is a function of Bayesian probability. The usefulness of any test depends on the pre-test probability of the patient having the disease. If a patient has active symptoms, that high baseline risk mathematically overwhelms the negative finding of a 0 calcium score. When the pretest probability is high, a 0 score is not enough to rule out a blockage. The negative likelihood of the test is too weak to outweigh the clinical symptoms. The PROMISE trial illustrated this. Among symptomatic patients with a score of 0, 16.5% were found to have non-obstructive coronary artery disease when checked with more advanced imaging. Symptoms are often the primary indicator that non-calcified, rupture-prone plaque is present and actively causing a lack of blood flow to the heart. This is why the 2021 AHA and ACC guidelines for chest pain changed the standard of care. For evaluating acute coronary syndrome, the recommendation is now CCTA, not calcium scoring. CCTA allows doctors to see the soft, non-calcified plaque that causes most sudden heart attacks. In a symptomatic patient, a 0 score is only a soft shield. It indicates a lower risk than a high score, but it is insufficient to exclude obstructive disease. To accurately use these scores, we have to look past broad averages and account for individual demographics. Women, for example, tend to have lower calcium scores than men, but they often carry a higher proportion of non-calcified, high-risk plaque. Symptomatic women are also more likely to suffer from microvascular dysfunction, a condition where the smallest vessels in the heart are diseased, which a calcium score cannot detect. Other modifiers matter just as much. A family history of premature heart disease independently raises a person's risk, even if their own calcium score is 0. We also look at the atherogenic index of plasma, or AIP. This is a ratio derived from cholesterol and triglyceride levels that correlates with major heart events, regardless of whether the patient has calcified plaque or not. The clinical framework for a 0 score is split. In the asymptomatic path, it serves as a warranty for de-escalating treatment. In the symptomatic or high-risk path, it is a soft shield that requires further investigation with CCTA. Treating a calcium score as a binary yes or no for heart disease ignores the complexity of how plaque actually forms and ruptures. Cardiovascular risk stratification is most effective when it integrates calcium data with soft plaque morphology, Bayesian probability, and the specific clinical phenotype of the patient.